Surgery for your child can be a nerve-wracking situation, both for your child and for yourself. Over the years, pediatric surgery has evolved such that we are doing more minimally invasive surgery so that the incision on abdomen or chest is so much smaller and your child will experience so much less pain as well as psychological trauma with the laparoscopic or thoracoscopic procedures. Laparoscopic or thoracoscopic surgery involves small cuts in the abdomen or chest, introducing small instruments in the abdomen or chest and doing the operation inside. This means that the recovery is so much better in terms of pain and also their suffering. This is much better for the young bodies that your child has. In the long term, all you see are tiny little incisions, scars on the abdomen or chest, and internally the recovery is much better. Join me in this journey of covering more about minimally invasive surgery, that is laparoscopic or thoracoscopic surgery. Hello, my name is Dr. Nada Sudhakaran. I'm a pediatric surgeon specializing in minimally invasive surgery. I'm based in Kuala Lumpur and the centers I work in are in Pantai Hospital Kuala Lumpur and in other hospitals within the Klang Valley. I've been a pediatric surgeon for over 20 years and I've been a consultant pediatric surgeon in UK as well as in Australia and now in Kuala Lumpur. My area of interest is minimally invasive surgery, which is either laparoscopic, which involve minimal cuts in the abdomen and doing surgery within the abdomen, and also in the chest, which is thoracoscopic surgery. I do surgeries for both newborn babies as well as older children. And this involves either reconstructive surgery or surgery to remove abnormalities either in the chest or in the abdomen. My mission is to provide most advanced laparoscopic or thoracoscopic surgery for children so that they have minimal pain and suffering and also psychological trauma following surgery. So the journey through surgery for the children is so much better. Over the years, pediatric surgery has undergone a whole lot of evolution. Initially, we started off doing surgeries, making large incision to get access to the abdomen or chest. And now we are doing minimally invasive surgery, which involves tiny little dots on the abdomen or chest to introduce small instruments to do the surgery within the abdomen or chest cavity. This has now allowed the child to recover so much faster and undergo less trauma in terms of pain, suffering, and quicker recovery, so that the surgery becomes a smooth journey for both the child and their parents. Being a well-informed parent is crucial, especially for the healthcare for your child. Being well-informed makes it easier for you to make decisions for what's required for your child, especially when it comes to surgical conditions. Often, surgical conditions springs up on parents, whether it's a newborn child or a child with an acute tummy or a condition that requires surgery. And in that point of time, it may be quite daunting for that parent. Therefore, knowing about conditions beforehand is quite useful, and knowing about what is available out there and what are the options is useful so that the parent can make the right decision during that time when the child requires surgery. Having the information allows you to work alongside a skilled surgeon much better so that the outcome for your child is smoother and the child undergoes less stress and less stress for yourself too. Laparoscopic surgery, often referred to as keyhole surgery, means using small incisions to introduce a camera into the abdomen and to introduce instruments to do the surgery within the abdominal cavity. On the other hand, thoracoscopic surgery involves doing the same with the cameras and small instruments in the chest cavity. This involves very small cuts, and therefore the recovery for your child is so much faster and the pain and suffering and scarring is so much better. By making small incision, the muscle is not damaged and neither is the skin or any other structures within. So the recovery for the muscle, which is the most painful part often after surgery, is so much less. So traditional surgery is something that's been done for many decades or even a century. And what happens with traditional surgery is that the surgeon makes a big incision either in the abdomen or chest to deliver the organ out or introduce your hand inside the cavity to do the surgery. This has been replaced over the last 20 or 30 years with minimally invasive surgery, which involves introducing a small incision and a camera into the abdomen or chest to visualize what's inside, and then small incision to introduce the instruments, which are tiny, to do the procedure within. Because you're making a small incision, the recovery is so much faster, the pain that your child is experiencing is so much less, and with regards to the scarring, it's minimal and in fact almost invisible down the line. There is a big difference between a pediatric surgeon doing laparoscopic surgery versus an adult surgeon. The difference is that a pediatric surgeon has been trained from the beginning to deal with the psychology as well as the physiology of a child. An adult surgeon may not be able to communicate or deal with the physical aspect of the surgery compared to a pediatric surgeon. The child's abdomen is so much more fragile compared to an adult. Pediatric surgeon doing laparoscopic surgery will be performing the surgery with smaller instruments, the 3mm versus the adult surgeons who often use the 5mm instruments, knowing that the child has got different physiology and their response to any form of surgery, especially laparoscopic surgery, is so much different. For example, when we do the laparoscopic surgery, we have to distend the abdomen with some carbon dioxide gas, and the pressures that we use is so much less, as well as the effect of the gas on the abdomen can be quite significant on the chest and the breathing of the child. So knowledge of dealing with pediatric laparoscopic surgery, the safety profile, as well as handling the tissue within the abdomen is so much more specific for the child versus the adult. The tissues in the child is so much more fragile and delicate compared to the adult. So the precision of a pediatric surgeon is more than the adult surgeon. So doing laparoscopic surgery will involve specialized training to be able to deal with minuscule instrument in a different terrain or different environment from the open surgery. Because pediatric laparoscopic surgery is so precise and so minuscule, you need the additional specialized skills and ability before you are able to do independent laparoscopic surgery for children. So to be a laparoscopic surgeon, one needs to be training to do pediatric surgery with somebody who is experienced doing laparoscopic surgery. Often in this field of surgery, it's an apprentice type of training, whereby you learn from the trainer or master over the years to do laparoscopic surgery. I often go to certain centers around Malaysia to train people to do laparoscopic surgery in their center so that they train to do laparoscopic surgery within their center and have the hands-on experience within their field so that the other people, the nursing staff, the anesthesia staff, anesthetic staff also learn how to engage with the surgeon doing the laparoscopic surgery. So laparoscopic surgery involves introducing something called ports into the abdomen. So basically they are like little straws that allow instruments and cameras to be introduced. The camera, which is very tiny, the ones that I use are 3mm wide, that goes into the straw-like ports that we can visualize what's inside. Then we introduce instruments to do the procedures. Instruments such as this is a 3mm instrument, which is a grasper. So you can see that when we use the handles, the outside, the instrument can move to do whatever you want it to do. And as pediatric surgeon, we use the smallest instrument, which is a 3mm instrument, so that the incision for the child is so much smaller than for the adults. Yes, pediatric laparoscopic surgery is safe. We've been doing pediatric laparoscopic surgery for over 30 years now. And over the years, things has been improving gradually, and now the safety profile is fantastic. So as we make small cuts and introduce small instruments in the abdomen or chest cavity, the cuts on the muscle, which is the most painful part, is minimized. In addition, the blood loss is also significantly less because the muscle is a very vascular structure. And in terms of doing the operation within the abdomen or chest, we get fantastic view of the structures that we're dealing with now in HD as well as 4K technology. Therefore, we can see minuscule structures and blood vessels to avoid any injuries to important structures. As a result of the small incision, the risk of bleeding, infection, and scarring is minimized. I prefer laparoscopic or minimally invasive surgery as a first preference. However, there are certain situations where it may not be useful or applicable. In those situations whereby a child has had multiple surgeries in the past with complex anatomy or scarring in the abdomen or chest, it may not be so useful. However, it can be an adjunct. For example, if a child who's had surgery before, we can introduce the camera to see what is happening and decide where the best incision is before you can advance to open surgery. There are some particular situations whereby a child has got a big tumor or mass in the abdomen that needs to be removed. There's no other way but to make an incision big enough to remove that structure. Therefore, laparoscopic surgery may not be applicable in those situations. So laparoscopic surgery is growing in numbers in Malaysia, especially for children. However, it all depends on the surgeon and the center. So some centers may have laparoscopic surgery, but the surgeon may not be able to perform more advanced procedures. However, simple procedures like inguinal hernias and appendectomies is much more readily available in most centers with pediatric surgeons. Now, for the more complex laparoscopic surgery involving reconstruction, only few centers provide it because the surgeon needs to have been trained to do those procedures. And not only that, they need to have enough experience doing that same procedure so that they have got good skills to provide for your child. Therefore, it's important for you to evaluate the skills and the ability and the experience of the surgeon that you would like to take your child to. So laparoscopic surgery involves small incisions in the abdomen, and thoracoscopic surgery involves small incisions on the chest. So how we do the surgery is that the incisions are made, the camera is introduced, and the surgery is done in the abdomen or chest. Because the incisions are so small, 3 millimeters in size, for example, for appendectomy, there'll be 3 little dots of 3 millimeters as opposed to a 3 centimeter incision for a standard open surgery. So as a result of this small incision, the wounds heal faster and the scarring is minimal. So parents don't get reminded about the surgery the child has gone through in future. As opposed to a big incision, is a constant reminder of what happened to the child in the past. One of the main concerns for parents when their child has to undergo surgery is the pain for the child. So they are mostly anxious about that and how the child will cope with the pain. The pain from surgery is mostly from the cutting of muscles. And with laparoscopic surgery, we do not cut muscles. It's a small incision involving the instrument going through the muscle as opposed to a proper cut for an open surgery. Therefore, the pain that the child experiences with laparoscopic surgery is negligible. In addition to that, the requirement for pain medicine, analgesia is so much less, and the duration of which they have to take the medication is much shorter. With laparoscopic surgery, the pain is minimal compared to open surgery. And therefore, the journey that the child will have to undergo is so much smoother, and the tears that they have to shed are less compared to open surgery. So the magic of laparoscopic surgery doesn't end in the operating theatre. It carries on to the post-operative recovery period, in that the recovery is so much faster. The child doesn't have to stay in hospital for longer periods. Most surgical conditions, the child can go home the next day even. And some simple surgery, child can go home within the same day. So the recovery is so much faster because the incisions are small and doesn't involve a big cut of the muscle. The child will go back into normal activities much faster with the laparoscopic surgery because the muscles are back into action much sooner. The parents do not have to spend time in the hospital with the child, and they can go back to their own work and also looking after other kids at home. This results in lower hospital costs due to the fact that the child doesn't have to spend much time in the hospital compared to open surgery. So post-operatively, we worry about infection to the wound sites. One, the size of the wound matters in terms of risk of infection. And with laparoscopic surgery, because the incisions are so small, the risk of infection is so much less compared to a bigger wound site. And secondly, when I do the incisions for laparoscopic surgery, they are so small that we can glue the tissue together. Therefore, having glue on the skin means that it is a waterproof barrier, and that reduces the risk of infection even more than a standard stitch incision would be. So the benefit for parents is that the wound heals very fast and they worry much less, because within a few days they notice that the wound has already healed, the child is back to normal. So the whole process of surgery doesn't only involve the physical aspect, it also involves the psychological and the mental well-being of the child. So as we know, children are not little adults. Their response to surgery, both physically and psychologically, is so much different. So for laparoscopic surgery, the recovery is faster. Therefore, the anxiety, the fear that the child will have to undergo is so much less. And that translates to the parents' anxiety too. When the parents see a child who's undergoing such trauma, such anxiety and pain, they get anxious too. For a parent to see a child who's recovering so much faster is less of a stress compared to open surgery. So inguinal hernias, bulges in the groin in the child, which happens about 1% of children, mainly boys. So what you see as a parent is groin swelling, which can be uncomfortable or sometimes painful. What it is that there is a hole in the abdomen whereby intestine or any other structures in the abdomen is coming through, and it can often go back in. So once you identify a hernia, the only treatment of choice is surgical. There are two options. One is an open surgery where they make a cut in the groin over where the bulge is, cut through the skin, the fat, and then the muscle, and arrive at the hernia, and then you repair the hernia. That is the open surgical technique. With laparoscopic surgery, we introduce small little incision in the belly button area and two other small incisions which are 3 millimeters in size, and we repair it from the inside. The benefit of this is that, one, you're able to do the operation very nicely without much damage to other structures. And secondly, we can swing the camera into the other side and look for a developing hernia on the other side, which is present in about 15% of children. The other benefit is that you can also check out the other structures within the abdomen so that it doesn't get caught in the hernia opening whilst you're doing traditional surgery. Laparoscopic surgery, you identify the structures, in position the structures in a nice manner, and then repair the opening. In the long term, the structures of the uterus and the ovaries are well positioned. So since laparoscopic surgery involves small incisions, the recovery is so much faster. The fear and the pain that the child has to undergo is much less, and the recovery is so smooth. Within a few days, they are back to normal. They are running around as they were before the surgery. So appendicitis is a condition where the appendix is inflamed. The appendix is a worm-like structure on the right side of the tummy, which is sticking out from the large intestine. So what happens is that the appendix can get inflamed, and when there's inflammation, there's progressive pain. If you don't treat it early, then the appendix can rupture and cause significant problems. One of the telltale signs of appendicitis is pain on the right side. Once you've seen a doctor, the only choice of management that I would advocate is surgery. There are two options of surgery. One is a traditional surgery where you make a cut over where the appendix is on the right lower part of your abdomen, or laparoscopic surgery, which involves 3 little incisions in the abdomen. The difference between laparoscopic and open surgery is that the laparoscopic surgery involves small incision, therefore the recovery in terms of pain so much less, and the stays in hospital is much shorter. With the laparoscopic surgery, you've got access of the whole abdomen. If there's any perforation, there's pus anywhere in the abdomen, the laparoscopic surgery can visualize everything and check all other structures so that there is no areas that are not visualized and dealt with. With the open surgery, it involves a cut at least 3 centimeters in size, and there's incision of the muscle, which is the most painful part. So for a child to undergo laparoscopic operation, the recovery is so much faster, stay in hospital so much less. The tears that they have to shed is so much less because it is not so painful. And therefore, they can get back to normal activities much faster. And that includes the parents who can go back to work and their normal activities much faster. So anorectal malformation is a condition whereby the anus and the rectum is not formed normally. In the boys, the commonest form of anorectal malformation is when the rectum is connected to the urinary pipe. So this is what we call a high anomaly, and these boys do not have an anal opening. So when they are born, when there's no anal opening, they will require something called a colostomy. A colostomy is an opening of the intestine into the skin so that the feces can come out, and that allows the child to feed and evacuate the feces into a bag. That's only temporary until the reconstructive surgery is done for the anorectum so that they have a new opening that is positioned in the muscular structure that can hold the feces when required, so they're continent in future. Laparoscopic surgery for anorectal malformation involves detaching the rectum from the urinary tract and then creating a new opening, attaching the rectum to the skin through the muscle so that there's continent mechanism later on in future. So by doing the laparoscopic surgery, it involves small incision in the abdomen and so much smaller incision in the bottom part. Traditionally, the open surgery involved a cut for the boys from the scrotum right down to the spine, which is a very large incision cutting through muscles. And that is the most painful part, cutting muscles. In this situation, whereby there's hardly any cuts in the muscle, the recovery is so much faster, and most importantly, the child undergoes minimal pain. So Hirschsprung's disease is a condition where there is no nerves in the lower part of the colon or the rectum. So what happens is that because there's no nerves in the lower part, the colon or the rectum goes in a spasm like that. It closes. So now the feces cannot go through it and the child cannot evacuate his feces. So there's a form of obstruction. And we call this a functional obstruction because the structure is there, but the function is not there. Therefore, when the child is born and has problems evacuating his feces, often we suspect Hirschsprung's disease, and the diagnosis is made by something called a rectal biopsy. Most of the children will have a short segment Hirschsprung's whereby only about 10 to 20 centimeters of bowel lower down is affected, and therefore in this situation we can do something called a washout. We introduce a small tube to evacuate the feces, until which point where the child will require definitive surgery. The definitive surgery will involve cutting off the abnormal part lower down and joining normal part into the bottom part of the anus so that there's functional ability for the child to evacuate his feces. The traditional operation will involve either a cut in the lower abdomen about 5 centimeters in size so that they can mobilize the intestine from the top and then join the intestine to the bottom end. Some people are doing the surgery all from the bottom end, which involves stretching the anus quite significantly so that they can get access to the colon to be brought down through the anus. This involves pulling on the very important and sensitive muscle, which can eventually lead to incontinence of the muscle. The laparoscopic method involves mobilizing the intestine from the inside using small incision on the abdomen. Once mobilized, we make the rest of the operation through the bottom end and pull the abnormal part through the anus and join the normal part of the colon down to the anus. This involves very little retraction on the bottom end and very little mobilization and interference to the normal structure from top end. With the minimal incision to top end and the bottom, the child recovers so much faster. So choledochal cysts are abnormalities of the bile duct. So these are little tubes that lead from the liver down to the intestine that drains bile that's manufactured in liver into the intestine so that there's digestion of fat. So the abnormality is often seen very early on. This can lead on to other symptoms such as jaundice, abdominal pain, pale stools, infection, and significant pain to the area. The long-term issues with choledochal cysts is also cancerous changes to the structure itself if not treated early on. So the treatment of choice for choledochal cysts is to remove this part of the abnormality and join a small part of the intestine to the part of the liver so that the bile drains into the rest of the intestine so that there's use of this bile for digestion. The traditional method of dealing with choledochal cysts is a large incision in the right upper part of the tummy for the child, which can be about 5 to 10 centimeters in size, depending on how big the choledochal cyst is and how difficult it is to mobilize. The current best method of treatment is by the laparoscopic method, which involves small incision in the abdomen, one in the belly button and 2 or 3 more in the abdomen, which are no bigger than 5 millimeters in size. With this, we can mobilize the choledochal cyst, take it out and join the intestine to the liver without much pain for the child post-operatively. The post-operative recovery is very swift, which means that the child is back into action and back home within 3 to 4 days, compared to an open surgery where the child lingers on with the abdominal pain in the ward for up to 10 days. So undescended testes or cryptorchidism is a condition whereby the testes hasn't come down to the scrotum. As you know, the testes are made in the abdomen and descends before the child is born. And if the testes doesn't descend all the way down to scrotum, if it's stuck somewhere, either in the abdomen or in the groin, it's called an undescended testes. So for this condition, the treatment of choice is surgical, which is done at about 6 months of age. If the testes is in the groin, it's a simple procedure whereby a small cut in the groin and the testes is brought down to the scrotum. However, in the conditions whereby the testes is not felt in the groin, the testes is most likely in the abdomen. In this situation, the best type of surgery for the child is laparoscopic, whereby a small cut is made in the belly button and 2 other small incisions made elsewhere to approach the testes. With the laparoscopic technique, the view of the sperm tube and the blood vessel to the testes is so much better, and we can make sure that we preserve these structures so that the testes does not get damaged or the quality of testes is reduced by reducing the quality of blood flow to the testes. In the open technique, a bigger cut is made in the groin. The view of the testes is not so good and there's higher risk of damaging those important structures I just mentioned. With the laparoscopic technique, the cuts are so small and the recovery for the child is so much better and the child goes back to normal function much faster. So hydronephrosis simply means holdup of urine in the kidney. So the cause of this hydronephrosis is either because of reflux, where the urine is coming back from the bladder into the kidney, or due to obstruction, meaning there's a blockage somewhere along the track between the kidney and the bladder. The commonest cause of hydronephrosis that I encounter is something called pelvic-ureteric junction obstruction, whereby the pelvis, which is the funnel that drains the kidney down to the ureter with a small tube, between that junction, there is an obstruction. That is often identified antenatally before the child is born, while the child is still in the uterus of the mother. And when the child is born, we do some scans to look for the condition and if there's progressive worsening of the condition. Once we've identified the problem and we've done some tests on this to check on the flow of urine from the kidney down to the bladder, if there is a significant problem in terms of obstruction, surgery is the option of choice. This is because if there is an obstruction to the kidney, there will be progressive damage to the kidney cells. Therefore, there's a need to do surgery earlier so that we can preserve the function of the kidney. The choice of surgery that I perform is something called laparoscopic pyeloplasty, which involves taking away the blocked part between the pelvis and the ureter and then rejoining them with a bigger opening so that there is no obstruction. This is done as a procedure which takes about 2 hours in surgery and they go back within 2 days. The recovery is so much faster with laparoscopic surgery compared to the open surgery because the open surgery involves a reasonable cut on the back of the child and involves cutting of the muscle. Therefore, the pain is so much more significant compared to the laparoscopic technique. So atresias in children is something that happens or present at childbirth. The child with an atresia, meaning a disconnected part of intestine, will not be able to either swallow or have food passing through the intestine. Atresia basically means a blind ending tube. And the atresia can happen in the esophagus, between the mouth to the stomach, or any other part of the intestine. The commoner part will be the duodenum, which is the part just beyond the stomach, the small intestine. There's a blind ending tube there. So we identify atresias in children either antenatally, where there is dilatation of the intestine on the antenatal scans, or mostly when the child is born. Esophageal atresia, although not common, is atresia of the esophagus, whereby there's a blind ending tube of the esophagus, the top end, and that's identified when the child starts feeding. At the initial feed, they might be coughing up or choking on the feed. When the tube is introduced into the esophagus, it coils up where the blind ending is. And that is diagnostic of esophageal atresia. The other condition is something called duodenal atresia, where there is a blind ending tube at the duodenum, just beyond the stomach. And that is identified again by vomiting following feeds. So this is diagnosed by X-rays, and once diagnosed, both conditions will require surgery. The surgery of choice that I do is laparoscopic or thoracoscopic, whereby small incisions are made in the chest for the esophageal atresia or in the abdomen for duodenal atresia. The recovery following laparoscopic or thoracoscopic surgery is significantly better for both conditions compared to open surgery, whereby for the esophageal atresia, we require a big cut in the chest or the abdomen for esophageal atresia and duodenal atresia respectively. What's more significant with the esophageal atresia is that with no muscle cutting on the chest, there is no long-term risk of chest wall deformity. In the open surgery, where you cut the muscle for the child, what happens in long term is that there can be a pull on that side and there can be a deformity of the chest and the spine. And that is avoided by doing a thoracoscopic esophageal atresia repair. Lung malformation in children are conditions whereby there's abnormalities in the lung. The most common condition for this abnormality is cystic lung malformation, whereby there are cysts instead of normal spongy lung. So the cysts are big, containing mucus, and this gives rise to risk of infection because the stagnant mucus is there. The other risk is an unknown lifelong risk of cancer formation. And therefore, with these two risks, the benefits of removing that part of lung, which is a lobe, is advised. The current best method of removing this abnormal lung lobe is by the thoracoscopic method. This involves small incision in the chest to detach the lung lobe from the bronchus and the blood vessels, and then removing it through a small incision in the chest without causing much disruption to the chest wall or the muscles. Therefore, with this thoracoscopic method, the child recovers so much faster and they get to go home within a couple of days. As opposed to the open technique, a large incision is required on the chest to remove the lung, and following this, there is significant pain because a significant amount of muscle is cut to get access to the area involved. Therefore, the recovery is slower, more painful. In the long term, there is risk of chest wall deformity, whereby the chest contracts because you cut the muscle, and then they could also give rise to risk of scoliosis or bend to the spine. Before any surgery, you need to have a one-on-one consultation with your surgeon so that he can explain to you the whole process of surgery, the explanation about the x-ray findings, the blood tests, and so on, so that you are put at ease and you can make the right decision for your child. That is, when or whether your child needs a surgery. The clinical process is not the only thing that parents need to think about. They also need to think about the emotional and the logistic aspects of their process for the surgery. This involves getting ready mentally for yourself and for your child to be ready for the surgery, and also organize other things like your work schedule, time off for looking after your child following the surgery. Overall, the whole process can be overwhelming for parents, but there's always support from your surgical team and from the nursing team that could give you support and also advice before your surgery. So a team that works together performing laparoscopic surgery for children would include the surgeon who leads the entire operation, assisted by a nursing staff who deals with the instrumentation and another nursing staff who deals with the laparoscopic equipment. In addition to that, the other key player is the anesthetist, who deals with the anesthesia for your child, who keeps the child comfortable and monitors the whole process of his physiology, breathing, and so on. All in all, in the operating theatre, there will be about 10 people involved with the care of the child during the operative period. The whole team also works together in a multidisciplinary fashion, whereby everyone involved has their own specific roles and making sure that the child has a smooth running throughout the operating process. So anesthesia is crucial for pediatric laparoscopic surgery. That is because the child needs to be completely relaxed and pain-free during the whole process. The anesthetist would use doses that are appropriately made for your child's weight and size, so that the child remains comfortable and has no problems throughout anesthesia and surgical episode. So safety is utmost priority for any child undergoing surgery. Strict monitoring is done, looking at all parameters, the breathing, the heart rate, and also pain control for that child during the surgical period. Although anesthesia can be very daunting for parents, the whole period is monitored thoroughly in a very strict protocol, so that every child who undergoes surgery has a safe and effective anesthesia. So once anesthesia is done, the surgery can begin. What happens first is to introduce the camera for the laparoscopy or thoracoscopy. So a small incision is made, the port or a little straw-like instrument is introduced into the abdominal chest, and then the camera is put into the abdominal chest. Once that's done, we will look around looking for any obvious abnormalities or any problems before subsequent ports are inserted in the abdominal chest, so that instruments can be introduced to do the surgery. The positions of these subsequent ports are also determined during the surgery when you had a look around with the camera. Once that's done, an instrument like this is introduced into the abdominal chest so that the rest of the surgery can be done. For example, for appendicectomy, the instruments are introduced to remove the appendix, and the appendix is removed through one of the smaller ports in the belly button. And once that's done, everything is checked that everything is in place, then we can subsequently remove the ports. Once removed, the little holes are closed either with stitch and mostly with glue on the skin, which is waterproof and prevents bacteria from entering the wound. The whole process of surgery may take anything between 20 minutes for a simple hernia repair to something more complex, which may take a few hours. Laparoscopic surgery is very safe and the standards we achieve is very high. So for most surgeries for children, parents are allowed to come into the operating theatre with their child. The child is given a gas mask to inhale so that the child goes to sleep. And during that period, the parents are encouraged to be with the child so that the whole process is not so stressful for him or her. Subsequently, once the child is asleep, the parent will have to leave the room and wait outside in the waiting area. Once the surgery is done, the child is moved to the recovery, and once the child is starting to recover, parents are then called back to the recovery so that the child can be with the parents and it's not so stressful for both the parents as well as the child, so that they're together. So following the surgery, the child would be pain-free because I would have instilled some local anesthetic to the wound site, and the child will be moved to the recovery unit. When the child starts to be aware, usually the parents are called in to be with the child so that the process is less stressful for him or her and for the parents itself. Once the child is back on the ward, the child is usually allowed to have some liquid and then subsequently solid feeds. And often for day case procedures, the child can go home the same day, and it's very easy to look after the wound sites because when I use glue on the sites, it's waterproof and child can have shower and function normally. Apart from the minimal pain that's experienced in the wound sites, the child is otherwise back to almost normal function within 2 or 3 days. With some of the complex laparoscopic surgery that I perform, such as for Hirschsprung's disease, anorectal malformation, or for choledochal malformation, the process of recovery is slightly prolonged compared to these simple cases. This is because in these situations, we use the intestine to recreate or re-function the bowel. And what happens then is that there is something called ileus, where the intestine doesn't function normally, or the intestine goes to sleep. It takes about 3 to 4 days before the intestine gets normal function again. In that period, the child will require some intravenous fluid so that the child remains well hydrated, and also probably some antibiotics to cover for risk of slowly regain the function of the intestine, which will be monitored by daily examination for the child. Once there is signs that the intestine starts to work, we will start some oral fluid first and then go on to solids later. This will take approximately 4 to 5 days before the child gets to normal functioning with regards to bowel function and also full feeds. And that time, the child can be discharged. Once the child is discharged from the hospital, usually I see the child again a week after discharge. And that's to check that the wound is all healed up and there's no problems with the recovery. For some situations, such as for inguinal hernia repair or appendectomies, that's the only visit that the child will require following the surgery. Just one visit after surgery and the child will be discharged from follow-up clinic. For other complex situations, for surgeries such as Hirschsprung disease, anorectal malformations, or for choledochal malformations where the repair requires prolonged review, the child will be seen in specific time period. For example, for a child who's had anorectal malformation or Hirschsprung disease, they'll be reviewed almost at a weekly basis for the first month or so, and then subsequently, when the child is doing well, the duration of intervals between each visit will be longer and longer. And usually the follow-up is up to about 5 years so that the child has normal bowel function before the child is discharged from my care. So the long-term outcome for laparoscopic surgery is fantastic. Risk of scarring the inside is minimal because we introduce very small instruments to go inside. So there's not much disruption of the internal structures. In addition, there is this little disruption to the skin or the muscle tissue. So therefore, the scars that we see visibly on the outside is minimal. And especially in the babies who had laparoscopic surgery, the scars are almost invisible. So the long-term outcome for both internal structures as well as the skin layer is fantastic. In addition to this, children who have had thoracoscopic surgery, whereby we done surgery in the chest, we don't disrupt the shape of the chest wall. Therefore, the chest wall deformity is minimal. If you compare thoracoscopic versus the open repair for cervical atresia in babies, we find that the chest wall deformities in the thoracoscopic repair is almost negligible, compared to the open repair, whereby when you do a chest x-ray, a few years down the line, you see a significant deformity of the rib spaces as well as a possible scoliosis or bend of the spine. There are lots more data and statistics regards to the use of minimally invasive surgery in children. So comparing laparoscopic or thoracoscopic surgery with open surgery, there's numerous what we call randomized control trial showing that there's vast improvements in the recovery rate for children who have undergone laparoscopic or thoracoscopic surgery versus open surgery, where they recover so much faster, less pain, and the trauma of the recovery process is so much better. So having all these data shows that we need to move on to doing more laparoscopic or thoracoscopic surgery, and it should be the first line procedure for almost all procedures for chest and abdominal conditions in children. Over the years, I've had the privilege of treating many children by the laparoscopic or thoracoscopic method, and the feedback that parents have given me has been overwhelmingly positive. This is because the parents are amazed at how quickly the child recovers from surgery. Even the children themselves recover so much better and they are back to the normal self much faster. And when I see them in clinic, they are not fearful when they enter the clinic, which suggests that the whole process, the whole journey that they've undergone is not a stressful and frightening one. As a parent whose child needs to have surgery, it's more reassuring for you to speak to other parents who've undergone similar experiences, or look at my website for references from other parents and feedbacks that they've given with regards to their journey, having had their children undergo surgery. Some parents may be anxious that the laparoscopic or thoracoscopic surgery, minimally invasive surgery, is a new technique, an untested technique, or has higher risk with regards to post-operative complications compared to the open technique. In fact, laparoscopic or thoracoscopic surgery has been around for decades and is a well and truly tested technique. The improvements have been done many, many years ago, and currently laparoscopic surgery has been functioning with great efficacy and outcomes for the last 20 odd years. The outcomes following laparoscopic surgery is so much better compared to the open surgery. It's like comparing an old traditional phone with a smartphone. We are now in a generation where we are using more advanced technique for better outcome. And this is what laparoscopic or thoracoscopic surgery offers you. Another misconception that parents may have is that the risk of complication is higher with regards to open versus the laparoscopic method. For example, one story that I've heard recently is that a parent had been told that doing the laparoscopic hernia repair has a higher chance of recurrence, that is hernia coming back, versus the open technique. In actual fact, the outcomes are identical. However, the process of doing the hernia repair done by the open technique goes through many layers of the groin area versus the laparoscopic technique, whereby we make small incision in the abdomen. And the recovery from the laparoscopic surgery is so much faster versus the open technique, and the collateral damage, which means that you are damaging other structures which is unnecessary to be damaged, is higher in the open technique. So laparoscopic surgery is so much better. Another misconception that parents may have is that the cost of laparoscopic surgery is higher than open surgery. So we break down the different components of the cost of a surgical journey, that is the pre-operation consult, the operation itself, the recovery in the hospital, and also the post-operative visits. We need to look at where the costs lie. So if you look at the pre-operative consult, the cost between open and laparoscopic surgery is identical. In terms of the operative surgery point of view, the cost may be slightly higher. But in terms of the operative recovery, if the child needs to stay a few more days, this is where the cost benefit arises, whereby with the laparoscopic surgery, the duration of stay is fewer versus the open surgery. And finally, the follow-up and the consults may require fewer consults because the outcomes and the recovery is faster. So let's look at the day surgery, for example, for inguinal hernia repair. The cost overall may be higher because there is no post-operative stay. So for day procedures, the overall cost for laparoscopic surgery is higher. However, the trade-off is that the child recovers faster, the collateral damage and the scarring is much better for the laparoscopic surgery. However, for children who've had complex surgery whereby they need to stay in hospital, the duration of stay is shorter, and therefore the trade-off of doing laparoscopic surgery is much more beneficial in this situation. I always advise parents to look for laparoscopic or thoracoscopic surgeons for their child. And this is because laparoscopic and thoracoscopic surgery is much better for any surgeries in the abdomen or chest. There are many more laparoscopic surgeons performing children's surgery in Malaysia. I know that for sure because I've trained many of them. In order to find the right laparoscopic surgeon for your child, here are 3 bits of information that I'll give to you. One is that you identify a surgeon who is experienced and skillful enough to perform this surgery. You need to look at how many surgeries the surgeon has performed and also the surgeon's outcomes. 2, somebody who you have the right rapport, you trust that surgeon and have got good communication both for your child and for yourself with that person. And finally, it's the surgeon, not the hospital, who's performing the surgery for your child. So look for the right surgeon for your child and not just the nearest hospital. Complications following surgery or during surgery, fortunately, is few and far between. The issues with surgery, the complication can arise during surgery itself or after surgery. The commonest possible complication that can happen during surgery is possibly bleeding. And during this situation, obviously the surgeon will have to halt the bleeding and making sure that there's no ongoing problems after surgery. Unfortunately, with laparoscopic surgery, with minimal involvement of muscular tissues, the risk of bleeding is significantly less compared to open surgery. When there's complications after surgery or once child is discharged, the commonest complication is either bleeding or infection. Bleeding can happen once the child starts moving. Often is very, very small and temporary, and the treatment for it is simple pressure with a gauze, and that should deal with the bleeding itself. If there is any risk of infection or there's redness or pus discharge from the wound, then you need to consult your doctor or your GP to get some antibiotics. Often for my patients, I would rather hear from my patients themselves and come to see me if there's any complications so that I can deal with the problem myself. Over the years, I've been getting more and more patients locally as well as regionally with complications following surgery previously done in other institutions. A recent situation where I've had a child with anorectal malformation and complicated with a urinary leak. I had to redo the whole operation. Child has had a stoma formation and also the repair done at the same time. The repair required almost 4 to 6 hours to perform, and fortunately the child is able to pass urine normally and open his bowels normally after a period of 6 months follow-up. Often for children, there is possibilities of repairing most of these complications. However, having to do a second surgery would mean going through previously scarred tissue, and the outcomes and the complications may be slightly higher. However, most of these cases, I'm able to perform and repair the problems. Some of these situations may require an adjunct to help with the recovery. For example, somebody who have had anorectal malformation repaired and there are some problems with it. When I redo surgery for the anorectal malformation, I often perform a stoma whereby the feces comes to a bag so that the repair area at the bottom is able to rest and recover without any soiling from the feces, so that the outcomes from the surgery is perfect. So you need to prepare yourself both emotionally and physically for the surgical episode. For one, you need to be calm yourself. Trust that the whole process will be a smooth one, both for yourself and for your child. With regards to how you emotionally and physically support your child, it's best that you bring something that the child likes, for example, his favorite toy, and also some media to engage him so that he's distracted from the whole episode during the stay in hospital and also on the way to the operating theatre. In terms of the experience in hospital, you would first go to the ward, and then when due time, the child will be wheeled to operating theatre. Often, one parent is allowed to be with the child in the operating theatre. So during this period, you need to distract your child with toys and also constantly stimulating or engaging with your child so that the child is not nervous and fearful. It is important that your state of mind is also good so that the child is not nervous. And often what parents feel is reflected on the child. So be positive, be engaging with your child, inform the child about what is happening, which is what most surgeons like myself will be informing your child and yourself, so that the child and yourself is kept in the know of what's happening. Once your child has laparoscopic or thoracoscopic surgery, the usual wound dressing that I use is glue on the skin, which is very useful because your child can immediately have showers. So the care for the wound is minimal. Unless there are issues such as bleeding or any redness or pus discharge from the area, which is highly unlikely. If that's the case, then you need to consult your surgeon or myself for directions as to how to deal with the problem. Other than that, what's important for your child is to have good nutrition, to have a healthy diet with lots of fruits and vegetables, with lots of vitamins, and also multivitamins if you have. Parents are told about many different foods to avoid, such as eggs and seafood and such. Generally, I do not see any issues with different food substances to give to your child after surgery. You can avoid certain seafood which can cause itchiness to the wound or to the body. However, a good diet is what's recommended. And finally, the emotional support for your child, because there is certainly some pain that the child will experience, which will gradually get better within a period of 2 or 3 days. So the emotional support and physical support is required for your child, and inform them that everything would improve as days goes by. And within a week where you see me in clinic, the child would have been back to normal self. The future of laparoscopic surgery is exciting. The use of this technique is widespread around the world, and most top centers in the world are preferentially using laparoscopic surgery. In addition to that, there is more advances in terms of the equipments, technological advancement with regards to the use of single port, which means instead of 3 little openings, there's single opening, and also the development of robotic surgery, which is an advancement to the tools that we use for laparoscopic surgery. And I think that with time, the instruments will be so fine and easily maneuvered such that we can do complex surgery in a fraction of time. When you meet your surgeon who offers surgery for your child, you need to consider whether the surgeon can offer laparoscopic or minimally invasive surgery. If it's something that the surgeon does not offer, then you need to consider whether you need to see somebody who is offering laparoscopic or minimally invasive surgery for your child. And if that's something that you would consider, then get advice from a surgeon that offers MIS or minimally invasive surgery. And then you can put together the two options and decide and make an informed judgment as to what you prefer.